any further delay, I'll turn it over to Dr. Stuebe.
Thank you. Can you guys, yes, I think, mic on? Can y'all hear me in the back? No? Okay, which way is on? Hello?
It sounds like it's on.
Okay. Can you hear me in the back? All right. So this afternoon I'm going to talk a little bit more specifically about how obstetricians can help moms to breastfeed successfully. Are there any OBs in the audience? Raise your hand. Okay, so how you can tell your friends who are OBs how to support breastfeeding. And just to remind y'all of some of the data around the baby-friendly hospital program, and you all are believers and know about it, but I'm hoping that I can share with you some ways of presenting it that may be helpful as you go back to your hospitals and your local efforts. So this is the non-working pointer. Paralyzed by the lack of pointer. I will go old school for the moment. So I have a personal disclosure that I like to share when I'm speaking about breastfeeding to obstetricians. And that is that I personally was delivered via C-section for breech in the early 1970s, and I had a routine 10-day postpartum stay, as was the custom at that time. And there we go. And I was formula fed, and I was brought home from the hospital sitting on my mother's lap in the front seat of the family car. You'll notice there's a New York taxi in the background. This is New York City, and I'm just being held, carried on my mom's lap, home from the hospital. And so I like to try and tell folks that in 2016, breastfeeding, like infant car seats, should be common sense care for moms and babies. And I want to tell you a story about this. What I originally wanted to do when I was going to use this picture was to juxtapose this with a picture of my mom with me in the hospital with this big smile on her face and a giant bottle of formula in my mouth. So I called my dad, because I wasn't sure my mom was going to be into this, and said, hey, can you bring those baby pictures when you come to visit? So they show up with this picture, but not the bottle of formula. Because my mother, who had no problem letting the world know that she drove me around without a car seat, was not interested in having herself put up on the screen, exposing her as having formula fed back in the 1970s, even though the initiation rate when I was born was something around 23%. So she was in really good company. And we talked a little bit about grandmothers this morning, but I think it speaks to the point that people carry this around for a long time, and we need to be careful in how we talk about it. On a Christmas morning a couple years ago, my mother showed up with the Harvard Guide to Children's Health from 1972 that she'd found in her library. And she had bookmarked the page that said, it doesn't matter whether you breastfeed or formula feed because the evidence suggests that they're both equally useful to babies. And she read that aloud on Christmas morning to make sure everybody knew that she was not a bad mother. So I just think I want to remind you guys that people carry this around, and we need to be thoughtful. So today we're going to talk briefly about the public health impact of breastfeeding for mother and infant. I'm going to do a little physiology of lactation, and I'm going to share with you the way that I teach this to med students and to physicians and to anyone, basically. And then look at how the 10 steps enable mothers to achieve their breastfeeding goals. So there are two key points that I want y'all to take home, and I want you to bring back to your communities. First, breastfeeding is a public health issue. Even in developed countries, infants who are not breastfed face higher risks of infectious and chronic diseases, and mothers who do not breastfeed face higher risks of cancer and metabolic disease. So this isn't, red car seat or green car seat. This is a health issue. And then your care, the care that women receive in maternity care, directly affects a chance of breastfeeding success. Both observational and randomized trials demonstrate that routine healthcare practices can enable mothers to meet their infant feeding goals or derail breastfeeding and increase health risks for mother and child. And I think it's really important when you're talking to the person who says, well, you're just going to force women to breastfeed, to say this is about making sure women who want to breastfeed have their best chance of succeeding. Because why would we recommend something and then make it really hard for people to do? Like, that would just be cruel. And I think focusing on this as enabling women to achieve their own goals helps get away from the guilt, choice, et cetera, extravaganza, and we'll talk more about that. So breastfeeding is a public health issue. These are data from the Agency for Healthcare Research and Quality, as well as some other meta-analyses looking at the increased odds of various health conditions in moms and babies who formula feed versus moms and babies who breastfeed. And as you all are aware, a lot of different diseases are more likely in mothers and babies who aren't able to breastfeed. Those include things like ear infections and pneumonia and diarrhea, which are a nuisance, but with the exception of pneumonia, typically not deadly. And then things like NEC and SIDS and leukemia that kill kids. We also know that breastfeeding is a women's health issue. Breastfeeding is a women's health issue. Because in women who are not able to breastfeed, we see higher rates of breast cancer, ovarian cancer, diabetes, hypertension, and heart disease. So making sure women are able to breastfeed is important if you're a women's health provider for mom's sake, not to mention for baby's sake. So it's because of those health associations that all major medical organizations recommend at least 6 months of exclusive breastfeeding, followed by continuation for a year, and longer if mutually desired. And in ACOG's committee opinion that came out 2 weeks ago, ACOG now joins the rest of humanity in saying continuing for a year and longer as mutually desired. I worked really hard for that, so very excited. Anyway, I won't get into how we litigated the wording, but anyway. And I think that's important to share with clinicians because there are a lot of doctors who make a funny face if a mom says she's breastfeeding a 9-month-old, much less an 18-month-old. Like, ew, what's wrong with you? And so when I talk to medical students, I say, if she's breastfeeding her 18-month-old, you give her a high five. Or you say nothing at all, but you don't make a face because the WHO recommends 2 years and beyond. And then these are data looking at Oklahoma and U.S. Breastfeeding rates for 2012, and then the Healthy People 2020 goals. As was mentioned this morning, Oklahoma is actually beating the rest of the country on exclusive at 3 months. So you guys go. Awesome. Yay. And it's pretty close on all these other metrics. So good stuff is happening here. But I think it's really important to think about a transition from, this is a World War II era poster, which was exhorting mothers to nurse the baby, your protection against trouble. Inform yourself through Health Bureau publications and consult your doctor. And for a long time, the language around breastfeeding was like, if you're a good mom, you better do this, because if you don't, you're a bad mom. And you better just pull yourself up by your bootstraps or your bra straps or whatever it takes and get that baby breastfed. And if you're not doing it, then you're just not a good mother. And we really need to move away from that. And I think in the last 5 to 10 years, there's been a real shift from this bootstrap personal responsibility, if mom's a good mom, she'll make it work, to recognizing all those circles that influence whether moms are able to breastfeed. And that was beautifully presented before lunch in the talk about that kind of transition from, well, whatever, to actually I'm going to advocate for breastfeeding and look at all these social determinants. Because we know that a lot of moms aren't able to meet their own goals. These were data looking at the prevalence of early undesired weaning. And what we found was when moms were asked how long they intended to breastfeed, and then we saw what happened, and we asked them if they breastfed as long as they wanted to, fully 2/3 stopped breastfeeding earlier than they desired. So moms are not achieving their own breastfeeding goals. And I think that's really important when we go to the CEO of the hospital and say, why is this important? Say, we have patients who come in wanting to do something that's good for them and good for their babies. And our practices are keeping that from happening. From a population health standpoint, that's got to change. Because we want moms to be able to do what they set out to do. And we want to protect the right of these moms to fulfill their feeding intentions. So in thinking about all the different layers, how many people know this Swiss cheese slide from the medical errors world, the people who are in QI? So we talk about how for something bad to happen to a patient, like a lot of holes in the Swiss cheese have to line up. And I'm kind of flipping that on its head and asking you to think about, for a mother's breastfeeding goals to become success, a whole lot of pieces need to line up. So baby-friendly maternity care is critical. Supportive family and friends, informed healthcare providers who actually know how to manage breastfeeding, and then adequate leave and workplace support are just some of the factors that need to be aligned for moms to meet their own goals. And again, I think if we talk about this as enabling women to meet their goals, that is much less charged than making women breastfeed, which is a totally different way of putting it. So the Surgeon General's report did a really nice job of moving away from this, every mom should just make it happen, to we need to create an environment. And the Surgeon General wrote, the time has come to set forth the important roles and responsibilities of clinicians, employers, communities, researchers, and government leaders, and to urge us all to take on a commitment to enable mothers to meet their personal goals for breastfeeding. And I think that's the call to action that the U.S. Breastfeeding Committee works really hard on, and that's really why we're all here today. In the new committee opinion, ACOG specifically talks about optimizing support for breastfeeding as part of obstetric practice. So the committee is about how can we help mothers meet their goals as opposed to why breastfeeding should happen or why breastfeeding is important. And that, again, was a deliberate move away from, this is all about mom making it happen, to this is about creating an environment for mom to be successful. And one of the key pieces in the statement, which I encourage you to take back to your OBGYN colleagues who are not here, is that clinical management of lactation is a core component of reproductive health care. For too many obstetricians, when mom comes in with a breastfeeding problem, other than mastitis, which most OBs can handle that they need to write for duct clocks, they're like, well, that's kind of in the baby's mouth, and the baby has a pediatrician, and I don't know, that's not really my territory. So, like, could you go ask somebody else about that boob, because baby's touching it. We have no problem checking breasts for cancer or ordering mammograms, but, like, the breast with milk coming out of it is kind of like, well, that's not really an OB thing. And we wanted to make clear that it actually is an OB thing, even though it's above the bikini line. Like, it's part of obstetric care. And I mean, somebody was talking about north of the equator is not my problem, being what their obstetrician says. Is that? Yeah. The brain also belongs to the woman and should be considered. So the whole north of the equator thing is deeply offensive on so many levels, but anyway. But because lactation is an integral part of reproductive physiology, all obstetrician gynecologists and other obstetric care providers should develop and maintain knowledge and skills in anticipatory guidance, physical assessment, and support for normal breastfeeding physiology, and management of common complications of lactation. So ACOG is saying if you want to call yourself an obstetric care provider, you better know how to manage breastfeeding. Going to take a little work to get there, but at least we've said that's the goal. And then I showed this slide earlier, again, getting away from the moms, you better do it. The miracle is you and the milk only moms can make. Whether you breastfeed, use donor milk, or neither, finding the right support can make all the difference. It's about the support. Best for Babes will cheer you on and help you navigate the booby traps, the barriers that keep moms from achieving their personal breastfeeding goals. So I think these are all ways of saying that the system matters. And the system matters particularly when it comes to maternity care. So your care directly affects a woman's breastfeeding success. These are data from the PROBIT study. How many people are familiar with the PROBIT study or have seen it mentioned somewhere? So PROBIT was a randomized control trial conducted in Belarus, in the former Soviet Union, in the late 1990s. And they randomized, I think it was 34 hospitals. Half of the hospitals basically implemented baby-friendly, and half of the hospitals continued usual care. And then they followed the outcomes for these moms and kids out now to teenagerhood for the kids. And what this slide shows is when they looked at the proportion still breastfeeding, based on only a difference in hospital care, in moms who initiated breastfeeding all the way out to a year, birthing in a baby-friendly hospital meant moms were more likely to breastfeed than birthing in a baby hostile hospital. Yes, I did say baby hostile hospital. So I think that the important message here is that if you're talking to people and they're like, it doesn't matter what we do, she's going to do whatever she's going to do anyway, it makes no difference. Like, who cares if we take the baby to the nursery? The data show that a year out, those couple of days are impacting mom's likelihood of being successful. And I think that's a really powerful message to share with our colleagues. So y'all all know the 10 steps, or you wouldn't be here, so I'm not going to read them to you, but I'm going to highlight a couple of them and talk about some strategies that I'm hoping will be useful. So a couple of people have mentioned to me that step 3 is a real challenge. How do you get prenatal care providers to do the teaching that's required to pass the baby-friendly inspection, which is key, and then also to help moms actually be prepared? So when I first started doing this work, I asked the logical question. Talking to mom and prenatal care about breastfeeding. Are you going to breastfeed or bottle feed? How many people have asked a mother that question at some point in their lives? All right. So it's a pretty straightforward question. But there's this catch. So she says, I'm going to formula feed. Then we have a little bit of an impasse. Either I'm going to say, well, I think that's a bad decision, which is a bad way to start a conversation. Or I'm going to say, okay. Or I'm going to say, well, have you thought about, but she's now stated her position, and I'm now trying to talk her out of it. And that's not a good way to start a negotiation. So the question that Laurie Feldman-Winter has taught me to ask, and I know Laurie's been out to speak here, so many of you have met her, is what have you heard about breastfeeding? And how many people have asked this question? How many people have heard some really amazing answers? All right, so all sorts of stuff comes up. And my favorite story, which may or may not be apocryphal, is the provider says, what have you heard about breastfeeding? And the patient says, well, I don't want to do that. It's too painful. And the provider, probing, says, well, tell me what it is about breastfeeding. What's the painful thing you're worried about? And she said, well, I don't know what they use to make the holes in your nipples with, but I am not doing that. So this is a first-time mom, and maybe she's seen a baby bottle and there's a hole in the end, and she's looked at her nipples in the shower and there's no hole, and she knows breastfeeding is painful, so clearly there must be some kind of piercing procedure, and she's not interested in signing up for that. So the provider could have gone in and recited chapter and verse about the risks of formula exposure and the reasons breastfeeding is good and the importance for maternal health, and cost. And if all mom is thinking is they're going to pierce my nipples, like, it's not going to work. But when mom makes this comment, the provider, to their credit, as the story is told, keeps a straight face and says, actually, we don't need to make holes in your nipples. The holes are already there. And the mom says, oh, well, then I'll breastfeed. Tell me about this. So again, if you don't ask the patient where she's coming from, there's no way you're going to find out what is actually standing between her and her decision to breastfeed. So the concept here is this three-step counseling. So you ask the open-ended question. Mom says, maybe she doesn't get into the holes in the nipples, but she's like, oh, my sister did it. Her nipples were all chapped and bloody. It was horrible. So then you respond in your own words, summarizing what the patient said. It sounds like you're worried breastfeeding is going to be painful. So that does something really important. It tells the patient that you actually listened to what she said and heard it and can actually put it in your own words. So you weren't going down your checky box list and being like, okay, the next question is about your car seat, and the next question is about what kind of birth control you want, and have you thought about whether you want to circumcise if it's a boy? No, you're actually listening to what she's saying. And then you use that as the jumping off point for your education. So here's where you talk about strategies for getting a comfortable latch. You tell her that we have lactation consultants in the hospital. Maybe you tell her Tina Smiley's story about if it hurts, it's a signal from your body to adjust the baby's position. But you're educating her based on where she is coming from. And I found this incredibly helpful. Not only do I use this when I talk with patients, but when I teach the medical students, I have a whiteboard, and I say, what have you heard about breastfeeding? And they shout out a bunch of stuff, and I write it all on the board, and then we talk about it. And we always talk about the same things, but they feel like it's their discussion as opposed to me with my PowerPoint yammering on about breastfeeding. So I encourage you to try that. It's a little scary the first time because you don't know what's going to come up, but after you do it a couple times, you know that all the same things are going to come up. So how do you do this? How do you operationalize this? Well, at Carolina Global Breastfeeding Institute, we've developed Ready, Set, Baby. This is freely available to download and print to use, and it's a flip chart. And so here is, what have you heard about infant feeding? And on the back of the flip chart, there are guidelines. There's a main message, and there are things to refer to, and there are discussion points for a person doing the education to share. And it's been developed so that volunteers can be trained to do this. So you don't have to have your obstetrician gynecologist who could be doing robotic surgery spending 45 minutes teaching about breastfeeding. You can have somebody in your office or even a peer counselor do this kind of work. Ideally a peer counselor, but even just a volunteer in the community who comes in. It comes with a booklet to which it refers that goes through things you've heard about breastfeeding and things to be aware of. And there are modules for skin to skin, there are modules for rooming in, there are a bunch of different modules that cover everything that your patients need to know for baby friendly. So this is a great resource, and it was funded by the Kellogg Foundation. If you go to the website, they want you to give your name and email just so we know who's downloading it, but there's no charge associated with it. So the critical piece here for clinicians to be aware of is that patients do listen to what their doctors say about feeding. And this is an older study from 2003, but they asked women, what did your provider and what did the nurses at the hospital want you to do? And what are you doing now? And they found that if the provider favored breastfeeding, they were much more likely to breastfeed. If the provider had no preference, they were less likely to be breastfeeding. So that neutrality actually lowers breastfeeding rates compared with a clear recommendation. And finally, if the providers favored formula, they were a lot less likely to be breastfeeding. But obstetricians systematically underestimate the importance of their advice. And this was a study that looked at whether the patient thought the provider's opinion was important and whether the provider thought it was important. So more than a third of women said, I care what my OB says, and only 8% of OBs thought their patients cared. So there's this mismatch between the OB being like, oh, well, it doesn't really matter what I do, and the patient actually caring very much what the OB has to say. One of the challenges when we talk about counseling the feeding decision is this concern about kind of making moms feel guilty and forcing them to do something. And so in the ACOG committee opinion, we spend a long time trying to kind of lay out the considerations around what's truly an informed consent discussion. So the first point we make is that families should receive non-commercial, accurate, and unbiased information so they can make an informed decision. So not the Infant Guide to Breastfeeding handout that's available in the office to make an informed decision about infant feeding. Also not the breast milk cures all illnesses and nothing else matters handout, because that's not evidence-based, but rather a truly evidence-based, thoughtful set of materials. We make the point that obstetric care providers should be aware that personal experiences with infant feeding may affect their counseling. And this goes both ways. So the OB who breastfed each kid for 2 years and thinks it's the best thing ever might be a little too heavy-handed and encouraging. And the OB who got mastitis and an abscess and weaned because she was a resident and feels terrible about it might say, it's really not important, don't even bother, because she's still processing her experience. And it's really important to recognize that we all bring our personal experience to the table. And when we're counseling and making a shared decision, we've got to check that. And we've got to step away and actually talk to the patient. We also note that pervasive direct-to-consumer marketing of infant formula adversely affects patient and healthcare provider perception of the risks and benefits of breastfeeding. So some moms have read everything, and they know they can recite the risks and benefits of different feeding methods. Other moms have gotten free samples in the mail because they bought a onesie at Gymboree, and they say, now even more like breast milk with special added blah, blah, blah. And they think it doesn't matter. And if we don't ask, because we assume that because they're purple, they're going to bottle feed, we may not have an opportunity to educate them. And then finally, in that informed consent process, we should support each woman's informed decision about whether to initiate or continue breastfeeding, recognizing that she is uniquely qualified to decide what is best for her and her infant. And I think it's important to recognize that a woman of sound mind with complete information may make a decision that formula feeding is what makes sense for her. And we can't assume that every woman who thinks otherwise has been duped or co-opted or is delusional. Because there are women who are going to decide that's what's going to work for them. And if we don't admit that that's possible, then we're not really allowing for a shared decision. My sense is that the vast majority of women do want to breastfeed, and if we made it easy for all of them, most kids would get breast milk. And if it were easy for all of them, the people who are now saying, I'm not even going to go there because it's too much of an uphill battle, would probably end up breastfeeding as well. And then a handful of moms aren't going to want to do it. And honestly, you know, wet nursing has been around since the Code of Hammurabi. There have always been women who don't want to breastfeed. And so I think it's really important to acknowledge there's some people who aren't going to want to do this, and our job isn't to get every last one. It's to make sure everybody who wants to has their best shot. My opinion. Tomatoes are welcome. So another way an OB can be really helpful is with some anticipatory guidance about medications. So this is a kind of graphic way of putting it, but how many people here have seen a placenta in their career at some point? Lots of placenta seers. How many people have seen a breast? How many people have seen a breast that looks like a placenta? Okay, that's concerning. But for the most part, the breast and placenta do not look the same, and they do not work the same. And that's so, so important, because so many people say, well, you can't take ACE inhibitors when you're pregnant, so clearly you can't take them when you're breastfeeding. Wrong. You can take ACE inhibitors when you're breastfeeding. Or they say, well, you can't take Coumadin when you're pregnant, so you can't take Coumadin when you're breastfeeding. Coumadin is highly protein bound. It does not cross over into milk. Mom can be on Coumadin postpartum, no problem. And in making those assumptions, women get incorrect information. And they decide they can't breastfeed because they think that a medicine's dangerous when it actually is not. Dr. Meerwood already gave a shout out for LACMED this morning. I will give another shout out for LACMED. When I talk to medical students, I say, get out your phones now. I want you to get out your phones. I want you to go to the App Store and download this while we're sitting here. Because whatever you go into, at some point you're going to see a lactating woman, and I don't want you to be a jerk and tell her she has to pump and dump after Tylenol. And that happens. So I think this is a really good resource to share with folks. Also important to know that some of the materials that the pharmacy prints out in that giant handout that most people don't read about drug safety will say things that are spurious about breastfeeding, like Zantac should not be taken by breastfeeding women. How many people have seen a baby on Zantac? Okay, so if babies can take Zantac, clearly breastfeeding women can take Zantac. But some of the older PDR drug information sheets are just sort of pulled into those databases, and so moms may go to the pharmacist and be told something that isn't accurate. So I always tell moms, if you get to the pharmacy and someone gives you a hard time, I want you to call me and we'll talk it through. But don't either not take the medicine or stop breastfeeding based on a pharmacist who doesn't know what they're doing. So now we're going to get into the in-hospital stuff. And I just want to do a quick refresher for everybody on breastfeeding physiology in a way that hopefully will stick for you to take back to other folks. So when we think about lactation, there's a bunch of different hormones involved. And we know that, oh, there's the laser pointer. So the hypothalamus is in charge of the anterior and posterior pituitary. And the two big hormones in lactation are prolactin and oxytocin. Prolactin stimulates milk synthesis, and oxytocin stimulates milk secretion. And it's the baby at the breast that triggers the milk ejection reflex that causes the release of those hormones. We also know that a lot of other endocrine factors are at play. Cortisol, thyroid, insulin, growth hormone are all implicated in milk production. And it may be that some of the reasons that, for example, some of our diabetic patients struggle with breastfeeding is because their insulin levels are not regulated in the proper fashion. After birth, it's the loss of the placenta and the fall in progesterone that is thought to trigger the onset of lactogenesis. So I want to talk for a minute about what I call the cycle of breastfeeding success, which is let down, latch, and moving milk, and the importance of oxytocin. So when I told you my first kid was born the night before the match, and I started my residency with my little breast pump on my back and going to the little pumping room. And for a long time, I thought it was like the incredible superpower of the pump that extracted the milk out of my breasts. And then I realized that that didn't make any sense, and learned that it's actually the contraction of these little muscle cells, these myepithelial cells that are wrapped around each alveolus that squirt the milk down to the level of the nipple where the pump or the baby can get it. And that contraction is driven by oxytocin. So now we're going to divert, it's after lunch, I'm trying to keep you guys awake, into a little Greek mythology. How many people took Greek mythology in middle school or high school? Have a kid who's read Percy Jackson, have read Percy Jackson? Okay. So this is Hera, who's the queen of the gods. And if you've read Percy Jackson, you certainly know that Hera and Zeus had a somewhat tempestuous relationship, because Zeus had a number of affairs with women who were not his wife, Hera. And through those affairs, he produced a bunch of demigod children. One of those children was a guy named Hercules, who those with younger kids who've been to Disney movies may know about. And this is Hercules right here. And the Greeks understood breastfeeding was incredibly important. And they believed that if a baby was fed the milk of a goddess, the child would become immortal. So Zeus thought Hercules was pretty cool, and he snuck him up to Mount Olympus. And Hercules is clearly following WHO recommendations, because that's not like an infant's back muscles, to latch Hercules onto Hera so that he would become immortal. Well, Hera woke up and said, "Who is this? This is not my kid." And her milk shot across the sky, becoming the Milky Way galaxy. So the word galaxy comes from galactose, which is the Greek word for milk. And I share this whole story because oxytocin is powerful. Oxytocin makes galaxies. And oxytocin is critical to babies being able to get milk. So if a mom isn't releasing that oxytocin, then the baby's suction is going up against these teeny little ducts. And it's like trying to drink out of one of those cocktail straws, but a really, really, really long one. And it's not going to go well. And we know that pain and stress inhibit the release of oxytocin. So this is my favorite study of all time, which is Niles Newton's work from 1948. And Niles was sort of a grandmother of breastfeeding physiology. And she was working on her PhD, and she was nursing a baby, and she had read that if you stress a cow while you're milking the cow makes less milk. And I grew up in New York City, so I have very little personal experience with cows. But apparently the way they tested this was that if you pop a paper bag over the cow's head while it's being milked, the cow will make less milk. This sounds dangerous to me, but be that as it may. Niles said, well, I wonder what happens if you stress a mother while she's lactating. So she and her husband designed a little protocol, and while she was nursing her baby each morning, they did test weights before and after. So this is control, 167 grams of milk. Then Niles put her feet in ice water while she was breastfeeding. Whole lot less milk. She had her husband ask her math questions and shock her if she got them wrong. I don't know that there was an IRB, but it was, she was the PI and the study subject, so maybe that was okay. And then she had him wrap a piece of gauze around her big toe and yank until it was painful. Concurrent with that, she got an injection of either saline or oxytocin. As you can see in the light blue bars, when she got some extra oxytocin, the baby could get almost as much milk as normal. And Niles inferred from that pain and stress inhibit letdown and prevent the baby from being able to access milk. And the paper is fascinating because she talks about, she can imagine how the first-time mother who's anxious and worried and the latch is uncomfortable is going to be more anxious and more worried, and the baby's going to suck harder, and there's going to be less milk, and you're getting into this vicious feed-forward loop where things are not going to go well. Now, when I give this talk to med students, they always say, can we give shots of oxytocin? And I say, how about we take mom's feet out of the ice water? Wouldn't that be a better solution? And that's what those of y'all who do clinical work do every single day. You sit down next to mom. She's worried. She's like, I don't know. I don't think I can do this. I don't know. And you reassure her and you chat with her. You make a joke. Mom laughs. And all of a sudden you hear the baby go, 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 and like milk is spraying everywhere because you have taken her feet out of the ice water. And I think this is such a powerful message about the importance of that connection between people to facilitate their good health and certainly the clinical work that we all do at the bedside. So the second part of breastfeeding success is latch. And here I'm going to teach, I'm stealing everything from Boston people,